formed with the generous support of Jeannie Ruesch. Jeannie and her husband Otto are pictured there. And our vision of the center is actually to cure every person with GI cancers. And if you know, colorectal cancer is the most common of the GI cancers. And if you ask people what they want, patients with this disease, I'm sure they want improved survival and they want to live a little longer. But if you ask them really, they want to be cured. And we need to get this language into our mission and our goals. And so it is our vision to do that. But we at the Ruesch Center know that we can't do that by ourselves. We're going to need to partner. One of the things, though, we can do is take the really cool science that's happening today and embrace it and begin to incorporate it in real time. Because as you know, most patients are receiving quote-unquote standard of care. And while the standard of care is much better than it was before, for many patients that doesn't have cure as an option. So we're really trying to listen to patients, hear what they have to say, take the latest information in science and medical technology and try and leapfrog ahead so that patients with colorectal cancers and other GI cancers have a higher chance of being cured. And of course, the beautiful story to tell of now stage 4 colon cancers, some of whom can be cured through surgical means, is just incredible and has begun the transformation that we're seeking. So we hope you will partner with us in that as well. Just to give you a quick background on who we are busy. We see a bunch of patients every year, about 700 new GI cancer patients every year. We have very active clinical trial participation, which of course is critical. The only way we as a community are really going to move the bar is if we all demand something different than the standard of care whenever that's available to us. We're also very interested in this thing you can see called the biorepository. In order to find needles, believe it or not, we have to build a haystack. So all of you patients out there who have agreed to give a tube of blood or fill out some stupid questionnaire or wait while your doctor entered information into an electronic medical record, I want you to pause and take a breath and thank you, because that's the haystack that we're building in order to understand better how to individualize treatment. Because believe it or not, of the many hundreds of you that are on the line, you all do not have the same cancer. You have different kinds of cancer. But until we really figure out how you sort into different molecular types, we really won't move the bar. At the big GI cancer meetings that we just got back from in San Francisco, I invited the keynote speaker, a woman named Sabine Tejpar, to talk about her and others in understanding that colorectal cancer may sort into 5 different main kinds of genetic types. And so until we start to embrace that and understand it, we can't move the bar as quickly as we'd like. So our strategy at the Ruesch Center is to walk the walk, to do the clinical research, to lead this molecular translational research changes that are going forward. We also, though, feel that our role is convener, and that's kind of what this meeting we had was about, and what we're doing tonight is to get people together to talk so we can jointly influence outcomes in clinical research and funding in GI and specifically colorectal cancers. And of course, we all need to sustain and grow, and so we want to get the word out of what we're doing and find partners on all fronts. So that's really where we come from. And as Erica and others mentioned, we had this great symposium in December. It's a 4-day event in the end. And the Chris for Life folks and the CCA folks brought people in from out of town, and we had long meetings about how we were going to change this. And this is just some of the advocacy work. You have to remember that we're not only advocating on our local level, but we're advocating on a global level. But advocacy not only is the 5K walks and Hill support and meeting support, research partners, it's all of these things that we have to do together. So as I've said many, many times, we are better together. If we're fragmented in our own corners and not coming out and talking with each other and, if you will, rallying together, we won't really move the bar. So we must work together in order to move forward in the world of colorectal cancer and GI cancer clinical research. All right, that's the preaching element of my comments, and I hope I've converted those who weren't converted already. But let's move on to what they really asked me to focus on, and that's really a summary of this whole survivorship thing. And don't worry, I only have, I think, 3 or 4 more slides, but they have a lot of things to cover, and so it'll give us a lot of chance to have some back and forth and discussion about what all this means. So first, I wanted to talk about the physical challenges. Now, you know, you get diagnosed with cancer and you get surgery often and you have chemotherapy either for a short time or for a long time. And of course, all of that stuff we do to you causes lasting side effects. And I think in GI cancers, particularly because of a drug called oxaliplatin, we struggle a lot with neuropathy. So everybody out there, hold up your hand if you have some neuropathy. I can't see, but I'm assuming that's a high proportion of you. So that's because of a cumulative dose of the drug oxaliplatin. For most people, yeah, other drugs can cause some, but this one's pretty notorious. And we're still figuring out, to be honest, how much oxaliplatin to give people. And many of you will have had 12 cycles. And of course, there's a big clinical trial going on right now that maybe 6 is as good as 12. And of course, 6 cycles doesn't cause neuropathy. But neuropathy is kind of mysterious for us. We don't really understand why people get it. We're not really good at treating it. And so this is an important physical challenge for a lot of our patients as they survive colorectal cancer. Fatigue is a big deal. We don't really have good ways of measuring it. I sort of ask in clinic, so what can't you do because of your fatigue? And I get all sorts of ranges of answers, but we're not really good at understanding just how tired you are, and we're not really sure how much of the fatigue is chemo and surgery and all of that, but how much of it is also the emotional side of cancer and all the extra stuff you have to do, not only to do your daily lives, but deal with your cancer. And I talk a lot about that with patients and trying to separate that out. Not that I have magic fairy dust that can make it better, but it's good, I think, for us to understand the sources of all of these things. A very common question we get is the question around chemo brain. And I know I will make some of you angry, but I'm not sure it really exists. It might, but when you pen patients down who've had chemotherapy, and you make them do these what are called neuropsych tests, so put the blocks in order, or solve the maze, or rearrange the letters. When you ask patients before and after chemotherapy to do those kind of cognitive functions, they all do very well. There's almost an imperceptible difference in performance. But if you ask patients who've had cancer and who've had chemotherapy, they almost always blame it on chemo brain afterwards, that they forgot something, they can't find their car keys, they can't remember somebody's name. There are a lot of little things that happen. And, of course, there's also dementia. Let's face it, some people have that. Let's face it, we get older, there's more stuff we have to remember. But I really wonder if chemo brain is, again, back to this emotional overlay, is that cancer patients have so much more to handle than patients who don't have cancer or who didn't have cancer. And the analogy I use in clinic is about juggling. And so, most of us can juggle 3 balls. I literally can juggle 3 balls. It keeps me out of trouble, I think. But, and that's life and work and family and all those things that we can juggle. But cancer, a diagnosis, is at least 2 more balls. It is the side effects and the appointments and all the stuff you have to do for cancer and cancer care. But it's also the emotional overlay of, am I going to die or I'm not going to die? Who's going to take care of things? And so that constant drumbeat of the emotion is more like 2 more balls. So very few of us can juggle 5 balls as we manage our lives and our cancer. So balls drop. And sometimes I wonder if what chemo brain is simply balls dropping, because we have so much more we have to deal with when we're cancer patients and undergoing cancer care. And we don't talk about it a lot, but skin changes are a big deal. Whether it's Xeloda or some of the new Erbitux and Vectibix, these cause dramatic skin changes in some patients. Dry skin, feet changes, things like that, and they're out there. And on the one hand, the 5-FU and the Xelodas, they treat skin cancer, so that's good. But on the other hand, there are some skin changes. So this is just very high level, some of the things that we do to people that alter your function afterward. But of course, there's other stuff that's out there, bowel changes. So almost everybody's had some portion of their GI tract removed as a result of this. And while I'm all too familiar with breast cancer and its treatments, and breast cancer surgery causes some significant changes, it's different when you have a few feet of your colon taken out. And almost everybody has some different bowel function afterwards, whether it's more frequent or sometimes slower or gassy or problems with certain dietary restrictions. And some people, of course, are extremely challenged, those patients with rectal cancers and radiation who are going 10+ times. And I had one of the most fun moments I had at the symposium was when people were, having a shock talk about how best to mix the Metamucil in order to limit the number of bowel movements every day. So the kind of common problems that patients have with colon cancer are not the kind of problems that are comfortable to talk about at cocktail parties and with friends, and they don't really get it. So these kind of fora are great opportunities for us to trade secrets so that people have better tips. Everyone's focused on nutritional issues, and the reality is we have no idea what to really tell you. But we do recommend balanced diet and the like, but a lot of time those balanced diets then ultimately mess up bowel function. So you're feeling sort of guilty that you can't eat what the book says you're supposed to eat because it messes up your bowel function. And finally, sexual function. I don't think we doctors, I think, are not very comfortable nor very skilled about asking about or counseling around sexual issues that come up with particularly colorectal cancer. And so these are things that clearly everybody faces and need to be dealt with. And the more we talk about it, the more we share, the better. So these are just a quick summary of the physical challenges. But I want to tell you, as a guy who watches a lot of patients take this roller coaster ride, I just need to share this so that you're all very much going through similar things. So I call it the emotional ride. It starts with diagnosis, and this is sort of the oh shit moment, I've got cancer. And it's terror. But it's sort of, like when you have a newborn baby or somebody dies, there's so many things you have to do, we distract you from the emotion of your new diagnosis. So you have to arrange things, and we're getting treatment. So as long as we keep moving, everything's going to be fine. So you're sort of staying ahead of having the emotion kind of settle in about what's been happening to you in the diagnosis. And then there's the treatment phase. And for me, at least watching patients, this is in some ways one of the most relaxed moments of the whole process, because you sort of have swallowed the fact that you have this diagnosis, but you're doing something about it. And it's all about managing the side effects in your life and trying to stay normal, because as long as you're getting chemo, as long as you're getting treatment, nothing bad can happen. So it's kind of this security blanket phase of the treatment. And then in terms of the survivorship strategy, so let's say you had stage 2 or 3 cancer or stage 4 cancer that's been resected, and now we're going to stop treating you. We're just going to follow you. And this is the OMG moment. So most people panic at this moment, because every headache, every funny bowel movement is your cancer coming back. And so you just watch anxiety go up. You're sort of unblanketed all of a sudden, waiting for the other shoe to drop. So it is this window of time which I find often the most challenging for patients as you try to renormalize and pretend like, I guess, you didn't have cancer and kind of get back to life when in fact you did have cancer and you're still worried about all sorts of things. It's sort of like when long-term prisoners are released back out into the wild, you know. They don't know how to behave or act anymore. And so I think this is a really hard time for patients. So I just want to kind of review a high-level list of things that you really should have thought about as you go through this. And you get so busy you don't really. And they're hard things, some of them. So first is, what are your life goals? What are you really on the planet to do? What will make you happy doing? And of course, these are all things that are important, whether you have cancer or not. So the second one is, what's more important to you? Erica joked at me, you know, how long do you want to live? What's important to you? The duration of your life or the quality of your life? I see a lot of 85-year-olds who aren't really that happy. You know, they can't find, they go to the bathroom in their pants, they can't remember things, they spend a lot of time alone. And so when my patients say, I want to live to be 90, I sort of look at them and say, really? Really? Because most 90-year-olds aren't that great. So decide in your head, or start to think about, what would you trade in quality for time as you balance that? We all want to live to be 90. There's no question, but everybody answers that, I want to be 90 as long as I'm fine, as long as I'm like I am now. But you need to sort of start thinking about the trade-offs. Huge issue. Can you deal with this on your own, or do you need help? And most people need help. And that can be everything from your village, your spouse, your family, to professional psychiatric help, to support groups, to online chat rooms that are fabulous support for patients and family. But don't do this alone. As a doctor, the patients I really frown at the most for taking care of are the ones that are single, don't have anybody, because I worry about them very much. And so as much as you're willing to share and bring other people in to help you, keep them in the loop. That's what living is all about, is sharing among others. And I know everybody hates this line, but all of us should have our affairs in order, not just cancer patients. So we should, you know, have that done so that you're not worrying about it. And so if some doctor badly says to you, you should get your affairs in order, you should say, I already did. So just be there with that. And then for those patients who are struggling with more advanced disease, the stage 4 patients, I really think balancing the need for hope versus the need for facts and reality. We had a lot of discussion at the symposium about this. So having some treatment, having options, was also having hope. And when folks no longer had treatment or options or strategies, they felt hopeless. And we as oncologists don't necessarily see it that way, but we're not the ones with the gun pointed at us. So our job on some level is to make sure and share with you the facts and the realities that we know today, not to try and dump water on your flame of hope, but so you can frame and decision make where you want to go from there. So recognizing yourself and recognizing the medical community, this natural tension between your needing some sense of hope and how you gain your hope, and the needs for facts and the reality why you're going to the healthcare provider in the first place, is to find out how you can deal with this going forward. So this is the part of the emotional ride. I want to shift gears to the communication strategies. So let me kind of give you an idea of what we're thinking when you come on that follow-up visit. First, we're glad you're alive. All right? So we are. We are just so happy that you're in the alive category. And so we also ask you about things that we might be able to fix. And we want to make sure that you're tracking and doing your screening and your scans and your labs and everything like that. So we want to kind of make sure we're doing the follow-up, but we're really focused on things we can fix. We're not focused on much else. We spend most of our day in oncology clinics, at least, focusing on patients who are not that, you know, a long-term follow-up patient for us is a joy. We get to catch up with you. We get to ask you about your kids. In scans, okay, we can actually talk about other stuff that's much more fun for us to talk about than metastatic cancer. But you also have to recognize the third bullet here, is that we're human. As much as we try not to be, we are. And we do care about you. And there are sometimes we do that better than others. And those of you who have nice, long-standing relationships with your doctors, you know this. You know that there are days when it's just not the right time to ask that question, and other days are fine. So we are human. We're doing the best we can, and we do care about you. So that's on our side. On your side, you know, from the way I think of it, is you're glad you're alive too, but now you want to get back to living. So what you need is sort of an agenda. So make lists of your issues that are important to you. Recognizing that we might not be able to fix them, but we may, who knows? So it's worth asking about. It's worth throwing out there. The other is to use reliable resources as you try and fix your own issues. Most of you, when we can't fix it, you'll try and fix it on your own, and there's a lot of stuff out there. And most of it, I would have to say, is probably not reliable. Of course, we can't vet everything that's on the internet and the like. But try as much as possible, and that's where groups like Colon Cancer Alliance, Christopher Life, can help vet that information for you. So as much as possible, go through those kinds of reliable resources to try and work on fixing your own issues. And then, of course, always recognizing this is both a physical and an emotional side to what you're going through, and try to recognize and balance those as well. So, sort of wrapping up close to the end, what is a survivorship plan? Well, believe it or not, it's a requirement. So we now, after January 1st of this year, are required to hand every one of you a survivorship plan. And it's only for those patients, though, who've completed treatment. That's where the law states, is that it's for those patients. So those patients who are ongoing with treatment, that sort of thing, in theory, we're not required to do that, but you can imagine why this thing would be a good thing to have for those patients, too. It's intended to be a summary of what we just did to you. So your stage, what treatment we gave you, the names of the drugs, the names of the medical team, all of that. So you have a good record of what just happened to you, at least from a technical side. It's also intended to be what's next. So what's your follow-up schedule? What tests are you supposed to have? Are there any referrals that might be out there? What lifestyle things are you supposed to do? Diet, habits, those kinds of things. It's supposed to be a written summary of our recommendations. Now, there are two kind of styles for this, and at the meeting we actually talked about this a bit, is that some centers do it themselves. Our center, we do it ourselves. So you'd come and see me if you were one of my patients through the follow-up period. But a lot of hospitals and cancer centers are actually having survivorship clinics. So, if they will, they farm you out, sometimes back to primary care, but sometimes to specific survivorship clinics. And there's really pros and cons to both of these things. Survivorship clinics are good, maybe the best in some ways, because they're really people who are trained in the rehab and neuropathy and sexual function and all of the things I listed that I, as an oncologist, it's not my primary focus, if you will. Primary care I worry about a lot, because they're so busy and they see so many different things that they don't really know what necessarily are the right follow-up plans and things. Many are fabulous and do this wonderfully, but some want you to go back and see your oncologist so that we're keeping track of what's out there. One of the cons, though, to going to a survivorship group or a primary care is that things change, right? So new recommendations come forward, new understandings about genetics and family history. So, for example, we learned a lot about inherited cancer syndromes over the last few years. And in long-term follow-up, if a patient has come in just to check on their scan, make sure everything's okay, and we've never done Lynch syndrome testing, well, we're going back and doing some of that testing, because we would do that if you walked in today. So there is some advantage to going back to your subspecialty care clinic, because in theory you're going to be a little bit more up to speed on what's changed in the world of your disease in colorectal cancer than those who are not doing it. So those are relative pros and cons, and everybody had great input and different feelings about this. You know it when it's good, you know it when it's not good. So you want to make sure and get good follow-up care. And then the last point of this is that it's, as I mentioned, it's not really built for the stage 4 no evidence of disease patient, this new group of patients with stage 4 disease that we are, cross our fingers, curing. And so it's more focused on the traditional stage 2 and stage 3 patient. It needs to be tweaked and evolved over time. So just some items that might not get covered but are supposed to be at least acknowledged in a traditional survivorship plan. So what you got such and such chemotherapy, 5-FU and oxaliplatin. Well, what are the specific side effects you would expect from those, and when are they expected to resolve? And that's supposed to be given to you in writing. Genetic testing. Do you need genetic testing, or is what we've got adequate? How often do you get follow-up testing? And that's one of the questions that was asked, and I'll come back to that in a minute. That's scanning and colonoscopies and all of that stuff. Very clear evidence around aspirin, exercise, and nutrition. And you need to be in written counseling given this information. What's out there for rehab? There's actually a nice growing industry around rehab and cancer survivors. So what resources are out there? Who would you go see? That kind of thing. Mental health support options that are in your community. Mainly just to re-point out to you at that point that you might need this. This might be a worse time for you from a mental health perspective than the actual treatment phase. How do you get a hold of us? If you haven't figured out by this time, you're in trouble, but most of the time we want to re-summarize who you call for what. So what's a primary care flu shot kind of thing, and what's a I have back pain, I worry, I have cancer kind of thing. So having some clear ground rules about, and permission, honestly, to who do you call for what. And I think that's my last slide. So I wanted to get to the questions that were thrown at me, and then we can sort of open this up for some broader discussion and more comments. So the screen benefits versus the radiation risks. So colon cancer is one of the few cancers where we do routinely do follow-up CT scans. And the reason we do that is, the only reason to do the scans is if we find, if they will infect your survival. So if we go down a few corridors at Lombardi to the breast cancer clinic, they don't do follow-up scans in breast cancer because they actually figured out that it doesn't matter if a patient is diagnosed with metastatic disease now or 6 months from now. It doesn't change that woman's overall survival. And so while that's a difficult discussion because many people do want scans, the general gestalt is that it's not worth doing. And many patients are grateful for not doing scans because they don't have to ride the scan roller coaster that we talk so much about during the meeting. But in colorectal cancer, we will often find metastasis in patients before a CEA goes up, before you feel it. And if we find it and remove it, then we cure some patients. So there is a survival benefit in patients who get scans. Now, how often should they be and for how long? Well, that's debated. Standards are somewhere around every 6 months for the first few years, and then annual year 4, annual year 5, and then sort of stopping after that. Because it's very rare for patients to have recurrence after 5 years, so the risk-benefit, the question that Eric is asking, is the risk of more radiation, is the risk, it's honestly not so much the radiation, believe it or not, it's the IV contrast that we give you, because that can actually damage the kidneys over time. So the radiation is not as much as you might think an overall lifetime and risk. We do worry about it, but it's, in our opinion, not that big a deal. There's the emotional roller coaster ride. We find some little thing here, some little thing there. Is that cancer? Am I going to die or am I not going to die? So those are all issues. So for us, we tend to stop doing scans at 5 years. Doesn't mean we don't keep following patients if they wish. but we do stop doing those because we think that's about where the risk line occurs. The second is about familial screening. So that's very different. If we figure out that you have one of these inherited syndromes, and only 5–6% of colon cancer patients have a known inherited syndrome, then it's very different. You need colonoscopies often. And some patients actually need surgery to remove organs in order to reduce the risk and choose to do that. So the familial screening is very different from those of us who are just sort of standard risk colon cancer patients. And the last question is probably the most fun for me, is what would I do if it was me? Now, you know, it's different when the gun's pointed at you. I will tell you that. It's easy to sit here and pontificate about this, how I would feel, how it would be. But the reality is I don't think I'd be a very good patient, or I'd be very cool about this whole thing. I probably would I'd go one way or the other. I would continue in my OCD way of obsessing about everything and wanting to be scanned every 12 minutes versus, you know, being so, who cares about it, you know, let's go out and live my life, that I wouldn't follow up at all. I think I'd probably be a terrible patient. I'm pretty sure about that. But honestly, I'd be on the side of wanting to know probably more. But I also know that scanxiety, I think that was the word that was used during the thing, is, you know, I see it in my patients. So in our clinic, for example, I tell my patients, as soon as you've had your scan, email me and I'll check and see, so that you don't, you know, so we minimize the duration of your scanxiety, if you will. So I know that feeling of which way is it going to go is really hard and challenging. So I'd probably do it every now and then, but also want to spread it out a bit. So those are my answers to the 3 questions. I've taken probably more of your time than I was supposed to, but I hope this has been helpful, not only sort of setting up what we need to do as a group and a collective around colorectal cancer, but also what was discussed and reviewed from a medical perspective at the Joint Alliance that we held back in December. So thank you all very much, and I'll pass the baton back to our organizers.
Thank you so much, Dr. Marshall. That was fabulous, and we're so appreciative. Next on the agenda, we're bringing together some survivors, a couple of survivors that attended this conference. The first one I'm going to introduce you to is my friend, Robin Braverman. She's a 12-year stage 4 survivor. She's been NED, or has shown no evidence of disease, for the past 10 years. And she and I have discussed ad nauseum, really, what it's like to be a survivor. We like to say we talk colon a lot. We do. She's going to tell her story, and she's going to give you a brief synopsis of her aha moment from having been at the conference. Take it away, Robin.
Thank you, Erica, and everybody. And I have my comments written out nicely and concisely. And if I mess up, it's really sad to know that I can no longer blame chemo brain for it. Anyway, here are my reflections from the summit, along with like a very, very brief bio. I was very thrilled and privileged to attend the Joint CRISPR Life Colon Cancer Alliance Summit in December of this past year. Many folks in both organizations know me and my story, but I'll recap it and keep it short. I was diagnosed in August of 2002 with stage 4 colon cancer. I followed surgery with chemotherapy, and a year and a half later, the cancer returned to my liver. I returned to the infusion chair for 6 months, had another resection, and followed up with another 5 months of chemotherapy. It's an unfortunate pattern so many of us have had to repeat. Before that last surgery, a natural medicine doctor had been recommended to my family. We consulted with him, and liking his idea of strengthening my immune system, I embarked on my last chemotherapy treatments. That last surgery was more than 10 years ago, and I'm thrilled to say that any surveillance has corroborated my status as NED. I'm truly lucky. People ask me if the success is due to chemotherapy, surgery, the naturopathic, or just good luck. To them, I say yes, 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 and yes. The truth is, no one knows. Now I find myself in a very enviable position, 10 years NED. And now I find myself in a very scary position, 10 years NED. Sadly, I've seen very little help for the long-term survivor. I'd like to add that, at this time I want to add that I'm Lynch positive as well, which adds just another layer of complications to things. Most of the focus in the past has been, and rightly so, on the newly diagnosed and on the as yet to be diagnosed. I think these organizations are doing a great job on raising awareness and prevention, and I do agree that's where the bulk of our resources should be going. But there is, to our great relief, an emergence group of survivors who have a new, unique need. What to do with someone who shattered all the statistics. So I want to say that it wasn't so much for me an aha moment as it was an ah moment. When I went to the room for the NED group at the summit, I expected just a handful of people. To my delight, the room was overflowing, all stage 4 survivors, all with the same issues. I'm glad to be among this brave group of trailblazers. We all were experiencing the same thing, have the same fears, the same survivor's guilt, and I'm really anxious to see the next step. Thank you.
Well, thank you, Robin. Appreciate your comments and having you come to the summit to participate. And I certainly appreciate your comments, and they were very insightful. We have another survivor, Kim Newcomer from Minneapolis, Minnesota. She is, I know she has a very interesting story to tell, and she is, I want to thank her personally for stepping up to the plate and helping out. We had a speaker that was unable to attend today, Charlie, but Kim has stepped up to the plate and agreed to help us out and relay some of the important items that she learned at the summit as well. So Kim, I'm going to turn it over to you.
Hi, and thanks everyone for listening to my story. I was diagnosed with stage 4 colorectal cancer at the age of 35 after spending a year of being misdiagnosed. I spent the next 3 years with chemotherapy, radiation, multiple colon surgeries, 5 lung resections, and 70 rounds of chemotherapy, I believe. So I was finally NED after 3 years. During my treatments, I always wondered if there was any other people like me out there going through the treatments and the emotions I was dealing with at the time. I knew they were out there, but it was so hard to find. I kind of stumbled onto COLONTOWN and on Facebook, and it was such a great place to find people like myself, a neutral zone where we could talk open and honestly with each other and share resources and treatments. And I was generally excited to hear about the summit of fighting a smarter war on colon cancer, because I knew there were still questions, and I still needed a few answers. So during the summit, we broke down into 2 separate groups, one for NED patients, no evidence of disease, and one for people in active treatment. I was part of the NED group, and we talked about building a survivorship plan, which was my aha moment because I'd never heard of such a thing. I never knew that there were other people out there that were struggling to find ways to move on and I'm sorry, to move on and get on with your life. I just figured I was out there struggling by myself, and I know everybody had that feeling of drowning and wondering what to do next. So for me, my aha moment was the patient coordinator maybe talked about having someone coordinate appointments, so you're just not kind of out there reaching for things. I also wish I could have attended both sessions, the active treatment. As soon as I got home from the scan, as soon as I got home from the summit, I had a scan, and it showed 2 lymph nodes that had doubled in size in the past 3 months. My doctor wasn't really worried about it at this time, but they're just monitoring them closely. They're still small, but I've exhausted all of my current chemotherapy, and I'll have to wait 3 months for my next scan to see what to do next. So for me, it would have been nice to be able to do both treatments or both, parts of the seminar, but from what I took away from it was the survivorship plan. We really need to work to find a way to coordinate everything for people who are NED, and maybe shifting back and forth into NED to active disease.
All right. Well, thank you very much, Kim. And to all the attendees out there, I know there's probably a million questions out there that we want to ask, and we're going to get to a mechanism where we can handle all those in just a little bit. But before we move on just a little bit, I do have one question for Dr. Marshall. It's from Amy. Doctor, Amy wants to know, why isn't anyone tracking me for survival statistics? They don't seem to know that she has survived. Can you provide Amy a real brief clarity on that regard?
So they might be, actually. So there's something called the National Cancer Tumor Registry, and every patient who is diagnosed with cancer in the United States is tracked. Now, it's a fairly loose track, meaning that once a year for all patients that I'm responsible for, and there's kind of interesting formula for how they decide which doctor is responsible for which patient. We get this piece of paper and we fill out a form that says alive or dead and treatment or not and those sorts of things. And for the most part, we kind of know, and so we respond. So the majority of patients are tracked. But you're right, that's not very accurate. It's not, it doesn't go in perpetuity. So if you've stopped following up, the answer can come back, I don't know how this patient is doing. So there are some techniques for doing that. There's also this law called HIPAA. HIPAA is a terrible law when it comes to public health and clinical research and those sorts of things, because in fact, I'm not allowed to just call you up and ask you if you're alive or not. If you're my patient, I can, but other groups can't. Now, if you're on a clinical trial, you are tracked. At most clinical trials, one of the primary endpoints is survival. So our research staff would reach out and call you once a year or every 6 months and find out. And then I'll be very blunt, if we don't get an answer, we look on Social Security websites and things like that that tell us if people are still out there or not. So we do track you. We don't track you as closely as we should probably. And honestly, I think it's a great question, and one of the things we could think about is how could we begin to, in today's world of, we enter our own data on everything by our cell phones, should we start to create something like that people are tracking and counting our numbers, if you will. I think that would be very powerful, particularly from an advocacy perspective.
Very good. Thank you, Dr. Marshall. The next steps for the project is the CRISPR Life, Colon Cancer Foundation, and Colon Cancer Alliance will be working together to create some transitional survivorship care plans. We want to discuss some of the side effects management and craft some plans that are going to be of meaningful value for survival and follow-up for our patients. Please look for those details in both the upcoming newsletters for both organizations as well as both media sites. While we're working on those, we do value your input.
So, everyone, this is Erica again. Get involved. We really want to hear your voice and have dialogue with you as we create the survivorship care plan that comes from you. We have 2 sites, one with Chris for Life COLONTOWN. We have a specific group set up for that called the COLONTOWN Longtimers Club. And then with CCA has myccasupport.org. They have a discussion forum, and I believe they have a thread that's titled Stage 4 Unmet Needs and Care Plans. So you'll get involved with us. Now, while I have your ear, I also want to tell you about an upcoming virtual roundtable that we're putting on February 19th, we being Chris for Life COLONTOWN. And it is going to surround the issue of caregivers. And you all, those folks of you in COLONTOWN know that our caregivers are called care partners. And our title that we're using is Poignant Questions Faced by Caregivers. We hope to have a really exciting panel discussion that will be Thursday, February 19th at 7 p.m. Kevin?
And the Colon Cancer Alliance webinar series will continue. Next month, February 18th, we will be hosting a What You Need to Know About Social Security Disability. Please join us from 7 till 8 p.m. Eastern Standard Time for that valuable webinar as well. Before we go, we're almost out of time here. We very much would like to thank Dr. Marshall for joining us and presenting tonight. It was great having the perspective of Dr. Marshall here and sharing some of the items that we reached as a group, and we surely value his time and coming tonight for this webinar and sharing with survivors across the country. I'd also like to thank our invaluable sponsors, without which we couldn't do this webinar series. We'd like to thank Genentech, Amgen, Sanofi, Pharma, Bristol Myers Squibb, Bayer, and Boston Biomedical.
That was wonderful, Kevin. Thank you so much. And I want to reiterate our thanks to our sponsors, to Dr. Marshall, to the Ruesch Center, and to the Lombardi Cancer Center for hosting us. For those of you that were not with us, we hope that you will look to applying for the next year's conference that we haven't started planning yet, but we will be planning, and we will have it at that location. Dr. Marshall, you are fabulous, and we really so appreciate your helping us through these, what do we call them, these difficult decisions that we have to make, and we appreciate your humor and candor. And to everyone that is here with us in this webinar, on behalf of the Colon Cancer Alliance and the Chris for Life COLONTOWN communities, we thank you for attending tonight's webinar. And we're done.
We're done. And we did record the webinar, and we will be posting that on our both websites and our newsletters. Look for that information soon. Thanks, everybody, for attending. Thank you, Erica. Thank you, Chris for Life Colon Cancer Foundation. Thank you, Kim and Robin, for attending. And thank you all for attending. Have a good evening.
Thanks, Kevin.
Thank you, Kevin. Thank you, everyone. Oh, I need it.